Hey everyone, I'm back for another episode of Get Reporting with Me with Dr. Matthew Leonardi. We're going to be looking at a different pathology on today's ultrasound, though there will be some familiar pathologies as well for those of you that have watched episode 1 already. I'm going to hopefully be able to take you through some standardized approaches for assessment of ovarian masses. So here we go. As usual, we're starting with a transvaginal ultrasound, although maybe there's no usual yet, since this is only episode 2. In this case, we are starting with a transvaginal ultrasound, and we have an anteverted uterus. Again, for orientation, we have our symbol here up on the left side, which indicates a little notch on the probe, which tells us which direction it's pointing. And so this is towards the front of the body, and this is towards the back of the body. This is an anteverted uterus, and our measurements are noted in the right lower quadrant here of the screen, right lower corner, 85 by 46 in the AP. And we can start to look at some features of this uterus already, but we can skip ahead to the cine, which is going to give us a lot more detail anyway. So as I indicated in the first video, we will stop and I just happened to stop on something very interesting, but we'll scroll through it. But why not just stay here for a moment? We have very, very clear depiction of a myometrial cyst, anechoic contents with a hyperechoic rim. We can appreciate that this anterior myometrium here has already quite a few fan-shaped shadowing effects noticed. Maybe we're going to have another myometrial cyst here. Let's have a look as we scan through. It looks like it. It looks like it. It's not as anechoic as this one was here, but I think that this is another myometrial cyst present. And this one's right at the junctional zone, whereas this one's a little bit further away from the junctional zone. So sweeping back to the beginning, scanning through. Sometimes that fan-shaped shadowing is much more clearly seen in movement than it is in still. So as we scan through, we see that fan-shaped shadowing really clear. This uterus may be on its way to being a really globular uterus. It's not quite super globular. We do have a relatively sharper angle of the cervix to uterus here, rather than a more straight, smooth line. Posteriorly, it's a lot more smooth. And we have a symmetry overall between the anterior and the posterior, nothing too dramatic there. So if we measure those two, a little bit more thick in the anterior, but I don't think it would meet the criteria for obviously asymmetric or a 1.5 times ratio. But because we're seeing more of the adenomyosis features in the anterior, it makes sense that there's going to be a little bit more hypertrophy there. Can pause again. This is the next clip. Have we captured anything else? There's another myometrial cyst there. You can see how in some clips, some things are more obvious than others. So the onus really is on the person capturing the pictures and the videos to show us what's there. In our posterior myometrium, we haven't seen a whole lot of very obvious adenomyosis features. We might be having a little bit of activity right here. It's kind of drawing my eyes to this area, but nothing to really classify per se at this point. So let's keep going through. And there we go. Beautiful picture that the sonographer has acquired here of several myometrial cysts, irregularity of the junctional zone. So yeah, lots of adenomyosis. Maybe some lines here or some buds here as well, potentially. There's something that they're capturing here. This one's a bit more bright white, much more hyperechoic, so a little bit harder to interpret. but this very likely represents another depiction of an echogenic line. And look, they did the same thing that I did, and not too different in terms of measurements, a lot very symmetric overall, just slightly more thick in the anterior, but wouldn't meet criteria for asymmetry, even though it's a very vague criteria. Here we have a cine loop with color on, and one of those MUSA features is translesional vascularity. Now, in the context of a more focal adenomyoma versus a fibroid, it can help with differentiation. In this case here, we do see maybe a little bit of a translesional vascularity type pattern here, kind of like finger-like projections. And we did note that that's where a lot of the adenomyosis was focused, in that anterior myometrium. So we might be seeing that vascular supply through those areas of adenomyosis. Not much otherwise. So there's that translesional vascularity in this region here. And then in the posterior, I think my sonographer here, if I'm trying to interpret what they're doing, since there's not obviously a dialogue per se with recording, and the annotations are really overall quite basic, but I reckon that they were trying to understand whether these were myometrial cysts here or not. And so they've put the color on and can see that those have color Doppler evidence here. Interestingly, as we're moving closer to the endometrium over here, we might be seeing an echogenic line, maybe two, and we're not seeing any of that vascularity filling this here. So these here might be more evidence of adenomyosis, whereas these are definitely not. A tip is that at the periphery of the myometrium is where you're going to find the arcuate vessels. And so it's less likely for you to find focal myometrial cysts in that area. Quite possibly if there's deep endometriosis and focal adenomyosis of the outer myometrium, you may, but that's usually a little bit more hypoechoic, almost fibrotic in nature, rather than that more true original adenomyosis that stems from the junctional zone. So here we have a transverse view, pausing it. There's a myometrial cyst. There's another one, fan-shaped shadowing. These are not surprising. Obviously, we've already seen some of these things in the sagittal view. And we're getting the ovaries in this view as well. So we have the left ovary just there and the right ovary over here. And we're already getting some sense that there's probably something going on in the right ovary. So our uterus has a volume of 114 mils, and that's pretty normal. Like we said a few slides ago, the uterus is not quite globular. There's a bit of a hypertrophy happening in the anterior myometrium, but it's not really globular in that light bulb-like depiction. We have a normal endometrium here, anterior endometrium, posterior endometrium. There's a midline echo all the way through. When we were scanning through, nothing was jumping out at me in terms of intracavitary pathology. And nothing has been captured either intentionally by our sonographer to depict that. Drawing your attention up to the cervix, we do have a few Nabothian cysts here. These are not anything to be concerned about. I do not report them unless they're very large, and that usually would be something like more than 3 centimeters maybe, only insofar as to help prevent future distraction or chaos. If somebody else scans and says that there is a cystic lesion present and they're not quite familiar with a Nabothian cyst, maybe there's going to be an accidental overcall or a bit of concern created for no reason. So I want to document that. Okay, they're still questioning this asymmetry clearly. So yeah, maybe in this view here, they're getting a little bit more 24 to 20, still not really quite enough to truly call it asymmetry. But there is a subjectivity, of course, and clearly my sonographer is getting that, and we're also getting that as we interpret this in real time. All right, moving on from the uterus. We're on to the left ovary. So we have left ovary here. We have clearly depicted by the calipers in 2 planes here, sagittal and transverse. And we have several anechoic cystic areas within this ovary. Now, keep in mind that this ovary is in its largest dimension, which is this measurement here, about 33 millimeters. And so all of these are going to be quite small, all within the realm of possible follicles. But we should never assume, and we should keep everything in mind when we're going through an ultrasound to be systematic. So here's our cine loop through this. There's one sweep through it there and another. I'll stop and we'll go through that slowly and talk about a few things. So as we're going through this here, one thing that's already catching my eye is this little collection here of hyperechoic foci. And so that's caught my eye. And then as I scanned through it, we also have a few hyperechoic foci here and then here as well. And I'll be honest, at this point in time, I'm not sure what these are. I've talked to a few individuals who are experts in gynecologic ultrasound around the world, and they're also not sure what it is. My hypotheses, there's a few. One is endometriosis. Shouldn't come as a surprise if you know anything about me. I'm a bit endo-obsessed. And so endometriosis in a superficial endometriosis depiction actually does look like hyperechoic foci, but usually lining the peritoneum. So maybe that, but that's not really the story here at all. Actually, I'm not sure if I even mentioned much of the story, but if I haven't, it's mostly becoming relevant now in that we're evaluating this patient for an ovarian mass that has been identified previous to this particular scan, identified in pregnancy and described as complex. And I know I'm kind of in a little box in the corner right now as the screen is showing the scan, but if you didn't see me up close, I did air quotations for the word complex because this is a word in my world that is a bad word. It's not allowed, but that was what it was described as previous to this scan. So what we're trying to do is evaluate for ovarian mass in this patient. And I don't think it's coming from this side because I'm not really getting a sense of any very grossly abnormal ovary. But because of that history, I'm wondering, are we seeing here potentially a small multiloculated cystic lesion? I don't think that's what we're seeing. I think what we're seeing here are just truly follicles and a number of them in development, but we should keep that in mind. And I don't know what these are here yet, but the other hypothesis, besides endometriosis, is that it could be physiologic changes with time. When the ovary ovulates, there is a trauma event. The ovary literally ruptures to spill an egg into the pelvis. And there's a breakage of the ovary surface, in which case there needs to be a repair. There's a tissue damage, tissue repair cycle that the ovary goes through. And as tissue does that, we do get healing processes, fibrosis, we get calcifications. Bright things are usually going to be a bit harder, more fibrotic, more calcified type tissues. So maybe what we're seeing is just normal. And we see them in different amounts in different people at different life stages. But this is one of those features that we should probably try to understand a little bit better. So that way we're understanding what's normal and what's not normal. So that's the left ovary, scanning through it just again there. In any of these little cystic areas, which are going to be described as follicles, there are no solid components. There should be a Doppler cine or at least a still. Here we go. Making sure that this is not dramatically vascular. Of course, we expect some vascularity. It's an ovary. So this is totally normal. Not too fussed about it. Lots of cines, which is my preference. And I think it is really the way forward because sometimes, like we saw in the uterus, one thing is seen better in one cine versus the other. And sometimes the more you get, the more you're able to find, which is really our job, is to find, is to be a detective and identify things that patients have, which warrant assessment, which warrant treatments. Moving on to the right ovary. So the right ovary is clearly a lot bigger than the left ovary. The right ovary in volume is almost 50 milliliters. And we are getting a sense here of some sort of cystic lesion. And I'm already getting a sense of a multiloculated cystic lesion. So we've got the scan through it, and this is the first scan. And then at the end of that clip, and we'll stop again as usual, at the end of that clip, I'm also seeing another cystic lesion, top left here, right under the annotation, which looks distinct actually. So there's this, and then there's this. There's that, and then that, and then that. Two things. So we're going to actually go through both of those and try to understand what each of them are, what each of them is, and be as detailed as possible in the characterization. So as we scan through this, we are looking at, do these cystic components connect to each other or not? Is this a unilocular or a multilocular cystic lesion? And you can see, for example, in this section right here, these two areas do connect as that cine loop is progressing through. So we might be able to describe this as a single locule, but I don't see a connection between this and this, for example, or this and this, or this and this. So we definitely have 1, 2, 3, 4, at least 4 locules so far. I would think probably this is more of a true follicle here rather than a locule, but it never hurts to stay on the side of caution and safety. And if there's uncertainty, describing something in a way that will be taken more seriously. Of course, we don't want to overcall things and create chaos, but sometimes if we're unclear, that should be our preference, is to stay on the side of caution. So as I'm scanning through this, not a whole lot is jumping out at me in terms of the contents, primarily anechoic, really. Maybe there's something going on here, almost a little bit in the same way as what we saw on the other side, some hyperechognicity, and then maybe something down here, but not so good. So let's keep going through. And there we go. So in that exact region, I'll just come back to that cine for a second. As you can see how if this was just a cine for me, if this was the only cine, I actually probably would not really truly be able to call that a solid component. However, as I'm scanning through it again, in real time with all of you, I'm now seeing this, which I didn't see, maybe because I was focused here, or I was focused on other things, so I didn't see that. And so there is something here. There is a solid component here at the periphery, maybe something here, and as we know from this view, there is something there. So let's look at this, measure it in 3 orthogonal planes as usual. Measurement 1, 8.4, measurement 2, 9.0, measurement 3, arguably the most important measure for differentiating between an irregularity and a papillary projection, as this is on the wall of a cystic lesion, a locule of a multiloculated cystic lesion. 3 is the measurement from the wall to its highest point, and it measures over 3 millimeters. The cutoff for a papillary projection is 3 or more millimeters. So this meets the criteria for a papillary projection. And in this particular capture, I'm not just looking at the size. I'm also looking at whether there is the casting of an acoustic shadow beyond this papillary projection. In this region right here, the sound waves are traveling through, and here through, and I'm looking for acoustic shadows right here. Now, acoustic shadows can be quite difficult, sometimes quite subjective, but in this particular scenario, I'm not seeing any. And I can also help you understand that if we look nearby, we might be seeing what an acoustic shadow is to be able to compare against. Things are often relative with ultrasound. So we have a bit of edge artifact here producing an acoustic shadow in this exact region right here, and that same region right here. And so should this acoustic shadow here have appeared here, then I would have described this as having an acoustic shadow. And that is a really important metric for the ADNEX model. But it's also just really important to understand the mechanism. As the sound waves are traveling through tissue, certain tissues allow sound to travel more or less. And typically, cancer type tissue is going to allow the sound to travel more through that tissue. And that's going to mean that we're going to see the area behind this papillary projection the same as next door to it. Whereas tissue like calcifications or fibroids or fibroadenomas, these are more dense tissue. These types of tissue generally elucidate an acoustic shadow. So we're not seeing that here, which is one of the most important lessons in this particular ovarian mass assessment. This is the other area. We're going to call it a solid area for now until we evaluate those measures on the bottom right. The other solid area that we did see at the second glance in the cine loop. And so in this scenario, what we're having here is measurements, again, 3 orthogonal planes. And what we're appreciating here, this is the width. Arguably, that's also measuring the distance from the edge to the outer aspect, and similar here. Number 1 and 2, both of those are actually, they're different. So what would have benefited me in this particular view is to understand, again, relativity and the directionality. So I'm going to go back to this. And I'm going to try to understand. So this is our transverse view here. This is our sag view here. So this is a sweep through sag, which means that this here is going to be our length. And then that would be measure 1 in this is going to be our length. And this is going to be our width. So in transverse, we were going to sweep through this. This might be at the other aspect of that ovarian cyst. So we could argue that 1 does not meet criteria for papillary projection, but 2 does. And so, like I said earlier, we're going to stay on the safe side here. We're going to be more cautious than less cautious. And let's call this a papillary projection. Let's call this a papillary projection because of that 3.2 measurement here. So this would be our second papillary projection. And you'll notice that there is an acoustic shadow here, but it's actually the same acoustic shadow that we were seeing here, which is just off of that area of the abnormality. So the acoustic shadow here is not actually from this area, it's from the edge of the interface between the anechoic contents and that cyst wall or septation. And so I don't think that this has acoustic shadowing either. We would see it actually a little bit more behind, and because the beams are traveling in that direction, we should see it a little bit more in that plane and a little bit more down here. So I don't think that there's acoustic shadowing there. Scanning through again, I think my sonographer is looking here at this area to try to determine whether that is another solid component papillary projection. This one is more on the septation. Generally, these are going to be considered more solid components rather than papillary projections, since it's not quite on the edge of it. And so in any case, that third measurement here, clearly, if we were going to try to utilize the term papillary projection, wouldn't be equivalent anyway, because it's just about 2.7 millimeters in its height, but can be described as a solid component. In terms of vascularity, as we're scanning through this, not really much. IOTA score 1 for me so far. IOTA International Ovarian Tumor Analysis Group. The scoring system is really not so helpful for adnexs, but it is helpful for simple rules. And in this case, based on the very high likelihood, though in real time, sometimes it's hard to process. I don't think this would be classifiable as per simple rules, so we would be moving on to more advanced tools. The vascular flow doesn't actually matter. But in this case, I see minimal to none vascularity, so I'd score it as an IOTA score 1. And my sonographer has put the colored Doppler box over those solid components there, over those papillary projections, nothing showing up. Overall reassuring, but not reassuring enough to say that this is not something to worry about. I think what my sonographer is trying to measure here, in comparison to what was measured earlier, is more of just what is the cyst versus what is the ovary. But for what it's worth, from my perspective, when the ovarian cysts are really encompassing the majority, the vast majority of the ovary, it doesn't make that much difference to me to extrapolate that the measurement of the ovary is the measurement of the cyst or vice versa. Sometimes I'll qualitatively describe that the size is the same, but there is a sliver or a crescent of normal ovarian tissue surrounding that cystic mass. That's not so much to help differentiate between cancer or benign, but it is helpful for potentially egg preservation for fertility. It is helpful to understand if you're the surgeon, there's a decent likelihood that you'll be able to salvage a good amount of ovary for future utilization, whether that's fertility-based or simply estrogen cycling through the body for other normal physiologic processes. Okay, so we're moving on to the other cystic mass that's also in the right adnexa. This one's actually a bit bigger, and so it's about 59 by 70 by 58. And you can see where the calipers are placed, okay? So they're placed at the outer aspect. And so this one is measuring this cyst wall as well, but it's a very thin cyst wall, which is something that often happens with paratubal cysts. They have generally very thin cyst walls. And we're not seeing in this picture or this picture any normal ovarian tissue around it. So most likely, based on what we've already seen, this is going to be an adnexal lesion, not ovarian. It'll be a tubal origin lesion. I call these paratubal cysts because they come off of the fallopian tube. They don't come off of the ovary, even though a lot of people use the word para-ovarian. They're, of course, next to the ovary. But I find paratubal to be a little bit more true to the origin in that they are coming off of the tube. And so it's unilocular in this picture. It does have, in this view, low-level echogenic contents, but very homogeneous. No solid components visible here at all to me. And as we scan through it, there's that other mass. We're getting both. This is a bit of an incomplete cine loop of that particular mass as we're starting in the middle of it. We actually don't come all the way back to it. So hopefully this one does. There we go. So we have captured the entirety of it. Really important for the reading physician to be able to see the entirety of it. So we're coming to that other wall there. And so, yes, it does definitely have some low-level echoes to it. It's homogeneous. There's another cine loop through it. What we are appreciating here is we're actually scanning it through the bladder. So we're getting a little bit of acoustic enhancement, making it look a bit brighter than it was. Let's just look back at this. So the bladder is a bit squished here, so a little bit less acoustic enhancement happening from that fluid in the bladder. But it is important to keep in mind because that can essentially artificially increase your echogenicity, giving you the impression that the contents have a different origin, blood versus serous fluid, for example. And most paratubal cysts don't have contents that have really much substance. They're generally quite serous in nature. They're not like endometriomas, though if you were to absolutely apply the iota benign descriptors or easy descriptors to this, you actually might say that based on that, this is an endometrioma. However, we know that this is not part of the ovary. Endometriomas don't exist in isolation outside of the ovary, and they're definitely not paratubal in nature. So I don't think this is an endometrioma. Also, it's not the story that we're being told here, so it's less likely to be the case. So scanning through it, nothing again is jumping out at me here, but really comprehensive. And then there's another little baby cystic lesion right next to it. Also, probably unilocular. I think, did we scan through it in this view? There it is, but just the end of it. Just a small little thing there. There it is again. Wasn't part of what we were looking at until our sonographer said, hey, look at this. So most likely those two together make up paratubal cysts. And then we'll just come back to the left ovary, maybe in the context of having really critically evaluated that right ovary. Our sonographer said, hey, let's go back to the left ovary just to make sure that we're not seeing any papillary projections or solid components. Always good to do that in real time, because you can't go back later and capture something that you didn't capture. So being really smart about it in real time is key. And then we're just concluding the scan with a few transabdominal images for the purpose, like episode 1, I mentioned, we want to make sure we're not missing a large pathology. Sometimes we get more information out of a TA scan versus a TV scan. Interestingly, you actually can diagnose the adenomyosis pretty accurately on this one. You see there's myometrial cyst, there's fan-shaped shadowing. It is giving a globular shaped uterus in this view, but we already know, we don't think that that's necessarily true, but it does have a bit more of a light bulb shape there. And then there's that cystic mass there on the right side, left ovary under here. We're getting that other paratubal cyst here, and there's that other mass, but it's not very clearly seen. There's a bit better. We've done some image optimization, getting even more confidence that they're two separate, but we can appreciate that the echogenicity on transabdominal ultrasound is more anechoic. So there's a lot of work that needs to be done in settings and the physics of ultrasound. And so it's really important to try and make sure that that is correct, and that it can really artificially change what you're thinking. So we'll leave you with this last image here. This is the TA view. Actually, let's come back to this as I just sort of sum up some stuff. We'll let this be the last image before I end this episode. In this case, we have a adenomyotic uterus, very obviously adenomyotic based on Musa criteria. We have what I would describe as a normal left ovary with several follicles present and some peripheral hyperechoic features, but those are ill-defined at this time in terms of an etiology. On the right side, we have a multiloculated cystic lesion with at least 4 locules, probably 4 is the right number, and we have overall 2 papillary projections and an additional solid component. The largest dimension of a papillary projection is key for the adnex model. The presence or absence of acoustic shadowing is key for the adnex model. The overall size and the number of locules are key as well. There are a few other aspects of adnex that are clinical in nature that can be plugged into the equation. Right now, the adnex model is going through some evaluation in Europe as a medical device. You can download the app, and there is an alternative website to consider using, which is the Evidencio website. However, unlike the original adnex calculator, in which case you can use it without a CA125 blood test, the Evidencio model you must use with a CA125. And in the world of imaging, we don't always get all that information, or it's happening after the scan is done. So I did know in this case that the CA125 was a normal level, actually. But despite that, our adnex model calculated this at risk of a borderline malignancy of around 12%. The overall malignancy category was just slightly greater than that, but the majority of the calculation centered in on borderline ovarian malignancy. And so fast forward a few months, we finally have received the pathology confirmation on this particular ovarian mass, and it is indeed a borderline serous cystadenoma. So we were quite correct in our prediction based on adnex, though, of course, the majority of that percentage still statistically suggested this was going to be benign. But there was enough concern here based on the features, based on the score, that this should be removed, and rightfully so. It was, in this case, rightfully so removed. So that was what we saw on scan. That's what we heard on pathology. And that back-to-back learning is really key in getting better. So if you're a surgeon as well as a sonologist, you get that in real time in many cases. If you're scanning for other people, you should discuss with them the cases. Make sure you try to get surgical reports and histology reports to get that feedback to get better. And hopefully through this Get Reporting with me, Dr. Matthew Leonardi, you're also going to get better day by day and help our gynecologic patients understand what's going on with their bodies, help their doctors understand what's going on in the body, so that way they can get the right diagnosis for the right treatment. Thanks for joining me for another episode. See you next time.